Good afternoon. Thank you, organizers, for inviting me to this talk. Today, we'll be talking about post-osimertinib treatment options. First-line osimertinib is the standard option for EGFR mutated patients. Either liquid biopsy or in re-biopsy, if patients were tested on T790M, then osimertinib is the standard therapy. After failure of EGFR TKI, mainly the standard is platinum-based chemotherapy, and it has a PFS of 4 to 6 months. Subsequent salvage therapies are there after EGFR TKI failure and platinum chemotherapy, but they have PFS of around 2 to 3 months only. As my previous speaker has elucidated these resistant mechanisms both to first-line usage of osimertinib and second-line usage of osimertinib, majority of the mechanisms are unknown, and main resistant mechanisms to osimertinib are divided as on-target resistant mechanisms and off-target. Coming to on-target mechanisms, it will be on EGFR receptor. These most common mechanism is C797S. The off-target mechanisms are bypass mechanisms where you with MET amplification, HER2 amplification, insulin growth factor receptor based, and ALK, and also AXL. The other modalities of resistant mechanisms are epithelial-mesenchymal transition and small cell transformation. Coming to the treatment regimens are in various undergoing trials. Main treatment regimen was amivantamab plus lazertinib. It is a phase 1B study in patients who has progressed on osimertinib. Lazertinib is a third generation EGFR TKI, and amivantamab is a bispecific molecule, and patritumab deruxtecan and other agents. I'll be discussing about them in further slides. Coming to amivantamab. Amivantamab is a fully human bispecific antibody which targets both EGFR and MET. FC portion has an immune cell directing activity, and it has granted an breakthrough therapy designation from FDA. And lazertinib is also a potent third generation TKI. These combination of these two agents is most studied and well used in osimertinib resistant patients. Coming to the Chrysalis 2 cohort update in this ASCO 2022, where 39 patients who have progressed on osimertinib prior therapy has a blinded independent review overall response rate of 21%, and seeing the water flow plot, majority of the patients had some or other response post osimertinib with this amivantamab and lazertinib. And coming to the most common side effects in this population was by usage of this amivantamab and lazertinib were infusion-related reactions, that was 78%, and rash, followed by paranoia, which is due to the TKI. More than grade 3 events were 16%, resulting in 4% discontinuation and 18% in dose reductions. Mariposa 2 is an ongoing trial which is assessing amivantamab plus lazertinib as first-line therapy following progression on osimertinib. Coming to patritumab deruxtecan, it's a fully human anti-HER3 IgG1 monoclonal antibody, which is linked to a topoisomerase 1 payload, topoisomerase 1 inhibitor payload, and HER3, coming to patritumab deruxtecan, HER3 is expressed in 80% of all the patients who are having EGFR activated mutations in NSCLC. In a phase 1 dose expansion study, patritumab was given as 5.6 milligram per kg every 3 weeks in cohort 1, which showed an improvement of overall response rate in 39% in 44 patients who progressed on osimertinib and platinum-based chemotherapy. Based on this study, FDA has granted again a breakthrough designation approval for this drug in this December 2021. Coming to the treatment related adverse events, 94% of these patients has any grade of toxicities, out of which grade 3 toxicities were higher, which is up to the tune of 54%. But majority of the toxicities are hematological toxicities such as thrombocytopenia, decreased ANC counts, febrile neutropenia, fatigue, anemia, dyspnea, and hypokalemia. Coming to the other options, a phase 1 trial, which is again updated in the ASCO this year, presented its final results of Osimertinib plus Nesitumumab, which showed partial response in dose expansion cohort in more than 3 out of 18 patients, which has met its primary endpoint with a median PFS of 2.3 months. Another phase 1B study using Teliso-V, which is an antibody drug conjugate, Telisotuzumab vedotin, is an antibody drug conjugate that is again targeting MET overexpression after failure on prior Osimertinib. The overall response rate with Teliso-V is 58% in 19 patients, and major treatment adverse events were sensory neuropathy, nausea, fatigue, and cough. Coming to other options, as previously discussed, in Tatoon phase 1 trial, phase 1B Tatoon trial, Osimertinib is combined with Savolitinib in a cohort of 18 patients and yielded an overall response rate of 67%. Most common grade 3 side effects were grade 3 transaminitis, and also pneumothorax and anaphylaxis was noted in 4% of patients, and other common side effects were a decrease in ANC counts. There were 2 deaths reported due to acute renal failure, and this combination is further being prospectively evaluated in Savannah trial. And again in phase 1B Tatoon trial, there is another cohort where Osimertinib plus Selumetinib was used as an intermittent schedule. In a cohort of 18 patients who had progressed on prior Osimertinib, it yielded a partial response rate of 23%. The most common side effects were diarrhea, rash, and nausea. Coming to the other options, in C797S mutations, we can combine first and third generation TKIs like Erlotinib plus Osimertinib. When someone is having an oligoprogression, we can continue Osimertinib plus local ablative therapy. When someone is having a small cell transformation, then we can use a platinum doublet with platinum and etoposide. Another coming to PD-1 antibodies, then findings from exploratory analysis of IMpower 150 trial is the only one which showed atezolizumab with combination of chemotherapy and bevacizumab has median OS of 13.9 months when compared to 10 months in chemotherapy alone arm post progression of Osimertinib. When someone is having a CNS progression, we can use double dose of Osimertinib plus local CNS directed therapy. Coming to other ongoing trials, Osimertinib plus TDM1 combination is used in Tremio study. It is a phase 1 and / phase 2 bar study. And other combinations which were employed were Osimertinib with BCL2 inhibitors or PARP inhibitors. There is another third generation TKI, Nazartinib, is used in combination with Trametinib. Thank you.